Improving Patient Care and Safety Through Bedside Reporting, PDSA by Christine Green. Plan, Do, Study, Act. What is a PDSA? PDSA stands for Plan, Do, Study, Act, and is a systematic approach to making changes for quality improvement. Plan is the stage in which one decides what change is going to be made and why. Do is the stage in which the plan is implemented. Study is the stage in which we review the results of the plan or action that was put into place. And act is the stage in which we decide which changes we are going to implement or keep, and if any changes to our plan need to be made. The stakeholders involved closest here are the patients, nurses, and the organization as a whole. The patients have an opportunity for improved satisfaction of nursing communication as well as better medical outcomes with less chance of errors. Nurses have the opportunity for an increase in accountability, more clear and accurate transfer of information leading to less errors, increased patient quality of care, and an increase in the patient's overall satisfaction. The organization as a whole will benefit as an increase in patient satisfaction will lead to an increase in revenue and Medicare reimbursements. Additionally, less errors in care will lead to less lawsuits and less costs involved in litigation and its expenses. What is Bedside Report, Transition of Care, and why is it important? Transition of care is the act of transferring information from one caregiver to another regarding the patient and the care of the patient. This could be during shift change, movement from one department to another, or simply a change from nurse to nurse within the same department. In changing to bedside reporting, the ultimate goal is to improve patient satisfaction and improve safety of care. According to the Joint Commission in a Sentinel Event Alert in 2017, inadequate handoff communication is a contributing factor to adverse events, including many types of sentinel events. In this report, they make several recommendations to improve handoff communication, such as standardizing content, using an SBAR, conducting a face-to-face handoff, using the electronic health record for reference, and monitoring success of the interventions. In a study done by Kimberly Radke with regard to the patient satisfaction due to bedside reporting, the project's intention was to improve nurse communicated well scores to 90%. After 3 months, she concluded that there was an increase from 75% satisfaction rate to an 87.6% satisfaction rate. It was not the 90% hoped for, but it was a significant improvement. In 2015, the hospital national patient safety goal number 2 was to improve the effectiveness of communication among caregivers, and number 13 was to encourage patients' active involvement in their own care as a patient safety strategy, both of which can be accomplished by the use of bedside reporting, which the AHQR defines as an opportunity to make sure that there is an effective communication between patients, family, and staff. The Agency for Healthcare Research and Quality has an evidence-based guide in which Strategy 3 states, the goal of the Nurse Bedside Shift Report is to help ensure safe handoff of care between nurses by involving the patient and family. In addition, this is an opportunity with which nurses can catch misses, such as medications given that may have not been charted to the EHR. This leads to accountability. Nurse accountability, employee teamwork, and ownership are also aspects of bedside reporting, as stated in an article on evidence-based practice by Stephanie Baker. She states, Bedside Shift Report drives staff ownership and accountability. She further states that it is an opportunity for real-time conversations in which not only patient care can be addressed, but the condition of the patient's surroundings, and any gaps in care or charting can be addressed face-to-face, nurse to nurse, holding ourselves and each other accountable. The expected standard of care will be bedside reporting for all nurses at shift change and for all patients when moving from department to department. In the case of the patient going from the emergency department to the floor, the nurse will accompany the patient to their new room and give report to the receiving nurse face-to-face in the presence of the patient. In the case of the patient moving floor to floor, the sending and receiving nurse will meet bedside at either the current room or the room the patient is being transferred to. In the case of a patient going for a procedure, the receiving nurse will receive face-to-face report from the sending nurse. A negative variance to this will be report that is given from nurse to nurse, face-to-face, outside of the patient's room or at the nurse's station, with or without chart review. A further negative variance to this will be report that is given via the telephone with no face-to-face report and outside of the patient's presence. In analyzing these manners of report, it is easy to see that report outside of the patient's presence, whether in person or via the telephone, will impede the visualization of the patient and their surroundings, as well as exclude the patient and his or her family from being included in the plan of care or from asking questions. It will deny the ability of the managing of coworkers and will hinder nurse accountability. The problem identified here is low patient satisfaction levels with regards to nursing communication and decreased patient safety. Possible root causes of this could be inadequately trained staff, poor staff performance, inadequate report, inadequate or incorrect information being provided, and poor time management. The most likely root cause of low patient satisfaction and decreased patient safety is a combination of all of the above. The potential solution identified here is to implement mandatory bedside reporting. In evaluating the effect of this solution, patient satisfaction scores will be monitored before and after implementation. Adverse events, sentinel events, and medication errors will be monitored and tracked before and after implementation as well. It is hypothesized that post-implementation of bedside reporting, training, and implementation, that patient satisfaction with nursing communication will improve, and that near misses, adverse and sentinel events, and medication errors will decrease, thereby improving patient safety and quality of care. In implementation of bedside reporting as a solution, staff will need to be trained on bedside reporting as the new set standard of care, as well as be retrained on reporting procedures, ensuring that clear expectations are set. Included in the staff training will be what information will be included. Although most nurses and facilities already use a standard SBAR method of conveying information, this will be the least complicated task. Training staff to use the electronic health record for reference while giving and receiving report will allow for lapses in charting to be identified, as well as identification of incomplete or inaccurate charting to be noted. Being bedside with the patient will allow for the patient themselves, as well as family, to ask questions regarding the patient's plan of care or interject information into the report with regards to any change in the patient's condition and new or resolved symptoms. This time will also allow for an opportunity for the receiving nurse to ask questions and quickly assess the patient and the patient's immediate needs. A qualitative study by Jeffs et al. In Enhancing Nurse Surveillance, Accountability, and Patient Safety states, there is growing evidence that nurse-to-nurse handoff at the bedside, referred to as bedside reporting, involving the patients in the reporting interaction has positive outcomes for patients, nurses, clinical teams, and organizations. In their study, they found two emerging things from nurses: clarifying information and intercepting errors, as well as visualizing patients and prioritizing care. Bedside shift reporting allowed an opportunity for nurses to check and clarify information with regards to the status and care planning of the patients, and in some cases were able to identify, intercept, and correct potential or actual errors in patient care. Also reported by the study participants was that engaging patients in shift report allowed for a trigger for the patient to share with the nurse any new information. reporting at the bedside allowed for nurses to do an initial quick assessment of each of their patients, which they viewed as a more accountable and accurate method of exchanging information. Ultimately, nurses viewed the change to bedside reporting as a positive in improving patient safety and increasing their accountability. The picture above shows the flow of communication through the patient from nurse to nurse in both directions, thus indicating the patient as the center of the report and information. Implementation of bedside reporting will be a 1-month process in which during the first week, a new policy will begin to be drafted outlining the new procedure for bedside shift reporting, including what will be the standard of care, what information will be transferred, the use of the EHR as a tool, the inclusion of patient and family, as well as the managing up of coworkers. Sharing the new process with staff members will be key as change can be difficult. So early on, informing the staff of the change to come will allow for time to process that change. Including staff members' input in the new procedure will improve the acceptance of the new process for a more smooth changeover. Whenever possible, all those who may be affected by change should be involved in planning for that change. Planning for possible staff resistance and how to deal with that resistance will also be included in Week 1. Week 2 will be further development of the policy, including staff member input where appropriate. Week 2 will also be dealing with staff resistance and keeping an ear out for negativity and staff's reasons for resistance, allowing for an opportunity to promote the benefits of bedside reporting. Weeks 3 and 4 will include the finalization of the new policy, as well as review by senior staff members, charge nurses, and upper management for additional input. Short training classes will be needed in small groups to train/retrain staff on the bedside reporting process, with a focus on being clear on expectations. During this time, effort will be placed on promoting the benefits of bedside reporting and how and who it will benefit. Continuing to maintain an open line of communication with staff for questions and answers will be important and aid in further acceptance of the new change to come. During weeks 1 through 4, pre-intervention surveys will be given to the staff with regards to nurse accountability, communication, prioritization, safety, and clarity. Additionally, patients will be given a survey to assess their satisfaction with care, communication, safety, teamwork, and inclusion in plan of care. These same surveys will be given out to patients for 90 days following implementation of the new process, and at the end of the 90 days, a follow-up survey will be given to the staff to assess their opinions post-implementation. Using Lewin's model of change, week 1 and 2 and 3 will be the unfreezing stage as the employees are made aware of the changes to come and input is solicited. During week 4 and the following 90 days will be the stage of change, or movement, in which the bedside reporting standard of care will become the expected practice. After the 90 days and the reevaluation of the change, based on the assumption that the change will have both improved patient satisfaction and improve their safety of care, the refreezing stage will happen. This is when it will be necessary to ensure that the change continues, that the staff are compliant with the new policy, and that support is offered where needed. Some barriers to address with regards to the stakeholders involved would be the workflow issues, HIPAA, and unsupportive staff. Workflow issues could be issues that prevent nurses from being able to perform bedside reporting, such as the inability to leave the floor. There may need to be put into place a float nurse or use of the charge nurse to assume temporary care of patients when the nurse is off the floor. Additionally, nurses may think that they won't have the time required to do bedside reporting. In fact, bedside reporting requires approximately 3 to 5 minutes per patient, in or out of the room, but in the presence of the patient, the nurse is able to give the patient a quick visual assessment and the ability to prioritize plan of care, which will allow the ability to resume patient care more quickly. HIPAA privacy issues could be a barrier in that sensitive information may be needed to be conveyed. However, in this case, the information that is sensitive can be conveyed outside the room, with further reporting taking place at the patient's bedside. Lack of accountability of staff and unsupportive staff could be a barrier, as change is difficult and sometimes uncomfortable. One solution could be a recognition program put into place to commend those that consistently perform bedside reporting. In evaluating the change, 90 days post-implementation, the nurses will be given the same survey they were given in the initiation, and scores will be compared. The hope is that nurses will have a more positive outlook in regard for bedside reporting, with scores increasing. Patients will be continually surveyed regarding their satisfaction of care, and comparisons will be made to surveys done prior to the change, with the goal of improving patient satisfaction. Further statistics and data will be collected and compared with regard to adverse and sentinel events, as well as medication errors. In comparison of these, if the improvements are not as intended, it may be necessary to make additional changes to the bedside reporting process. Benefits to the organization itself won't be evident initially, as the financial impact of reimbursements will take some time to be monitored and evaluated. As planned use study acts as a continual process, minor changes may need to be made, and it may need to happen multiple times to reach the ultimate goal. It is, however, a process that is organized and effective, in which changes can be made and goals can be reached. Thank you for your time and attention.